That's money. Especially
it stays here.
Let's take it down.
Your
then they bring in the this if they can get there, then has them.
they have.
The network also is very poor.
Sister, don't be Huh? Huh? We already had a hammer. Hey, I can't spell that. Eh? I can't spell that.
Good afternoon, everyone who has logged in, and the team member. Happy New Year to everyone.
Thank you.
You're welcome to this interesting session of today, the first of its kind in 2023. And we are glad that God has given us life to meet today to share some knowledge and skills to perfect our service delivery in the EMS. With me, we have members in the room. We have experts, and we shall be hearing from them. They have packaged for us a lot, and since you hear the word experts, we expect a lot from them. And after this, we shall request that you practice in the EDs wherever you are in the country. By the names, Auma Winfred, and clinic officer, Masaka Regional Referral Hospital, working at accident and emergency, and I've also specialized in emergency medicine, but diploma level from MAST. That was 2017, 2019, and glad I got a convocation prize award for that lot. With me, we have members who will introduce themselves, but before that, we have the program layout for today, which is going to take 2 hours. And the program layout is, we shall have some pre-test, we shall have case scenario presentations, we shall have PowerPoint presentation, some demonstrations, case scenarios, questions we shall have to discuss, that is engaging audience, and the experts will give us answers or concerns. Then we shall have a post-test. We shall see how a cardiac arrest happens, and then what we are supposed to do in facility and out of facility. So the experts have prepared for us something. I don't want to preempt their information. I just request that when you're online, please mute. Unmute when you've been told to do so that we avoid interruptions. Then, when you have concerns, forward it. We shall see how to answer your concerns. After the program layout, I would request maybe we go through, though it was on the spot advert, but we had the sessions, what will be handled during this session. We are going to look at principles of cardiopulmonary resuscitation, that is CPR, recognition of a deteriorating patient, and how you prevent a cardiopulmonary arrest. And then after doing a CPR, what do? We need a post-resuscitation care. And I think this is where we get issues. We don't know after CPR, what next? We always leave our patients to again deteriorate and die. So, with me in the house, allow me call upon the panelists to introduce themselves. But before that, I welcome all of you once again to this program. Keep tuning in and keep on, not in and out of the room or out of your screen. So I welcome you members. Introduce yourselves, tell us more about yourselves so that we can know you. Some people know you, but there are those who don't know you. Yes, and this is area of expert. So Dr. Kavuma, I can begin with you.
The camera is already on me, so I've chosen me. All right, I'm called Kavuma Peter. I'm a medical doctor, and for this session, I am the course director for the advanced life support, basic life support, and immediate life support, as well as an instructor in all these courses. So I'm glad to be here, and I'm glad that I'll be passing on some knowledge and skills to you guys today.
Thank you, Dr. Kavuma. We can listen to another expert in the room. Welcome, Dr. Doreen.
Good afternoon, members. My name is Doreen Okong Alalate. I'm an emergency physician by profession. I work at Kampala Capital City Authority, and my role there is to support emergency medical services for the Greater Kampala metropolitan area. I am also an instructor under Emergency Care Courses Uganda, certified by the European Resuscitation Council, where we teach basic life support, advanced life support, and immediate life support courses for different emergency care providers. Glad to be here. Thank you.
You're welcome, Dr. Doreen. Next is another panelist, and that is Andrew.
Good afternoon, members. My name is Andrew Kamau. I am a nurse by profession and have about 9 years of work experience, mostly in the intensive care unit, and I'm glad to be here.
All right, so thank you for those introductions. We have other members, but yes, we've already welcomed them on the team. We shall see more as they join us. We shall have a pre-test. We want to assess the knowledge, the level of knowledge you have individually, and it will take us just a few minutes. So if we can get a pre-test. So the first question: which of the following vital sign reading in a 40-year-old patient is most likely to lead to a cardiac arrest if not attended to urgently? Single circle. I repeat, which of the following vital sign reading in a 40-year-old patient is most likely to lead to a cardiac arrest if not attended to urgently? A, Temperature 35.5 degrees Celsius. B. Blood pressure 175/85. C. Respiratory rate of 4 per minute. D. Heart rate of 140 beats per minute. We want only one choice. Answer, submit. Are we clear on that? All right. Question 2. Submit question 1. And this is question 2. I've not received it. Question 2. Okay. Fine. Question 2. What is the best time to ensure a hospital emergency trolley is well prepared? Question 2, I repeat. What is the best time to ensure a hospital emergency trolley is well prepared? Single choice. 1, weekly check and refill. B, daily checks. C, when expecting a difficult case. D, during the monthly stock check and refill. That is number 2. Number 3, what is the ratio of CPR to bag and mask ventilation, or BVM, given during a cardiac arrest? What is the ratio of CPR to a bag and mask ventilation given during a cardiac arrest? Single choice. A, 100 to 10. B, 15 to 2. C, 30 to 2. D, 3 to 1. And all these questions, remember, our topic today is adult resuscitation. So when you answer, look at adults, not pediatric. Question 4. What is the first thing to do when approaching a patient out of hospital with a possible cardiac arrest? I repeat, what is the first thing to do when approaching a patient out of hospital with a possible cardiac arrest? Single choice. A, immediately start CPR. B, call for help. C, give rescue breaths. D, ensure your safety. We have only 4 questions for you. That is a pretest. Remember, we are dealing with adults, not pediatric resuscitation. Thank you. So as Thank you for your responses. Half of you have submitted. Next on our agenda will be a case presentation. And our colleague has just joined us. We shall request him to introduce himself and then give us a case presentation for the session. You're welcome, Mr. Lu. I don't want to mispronounce your name.
I know. Good afternoon, everyone. My name is Dr. Lutako Mejamada Aldin. I'm an EMT at Masters Medical Center, as well as an advanced cardiac life support provider. I am the program director also at the Hepatitis Aid Organization, which is a civil society organization helping people that are facing challenges with hepatitis, and those that don't know, we help them to find out their status. Today, I'm going to take us in the case presentation. I'm also glad for the ECHO EMS program because it is helping a lot of health workers to better their skills in managing emergency cases. Thank you very much. Today we are going to be seeing a case. It was a real-life case in adult resuscitation, and it is going to be presented by me, Dr. Lutako Mejamada Aldin. The demographics of the patient. Yes, we can go on. Yeah, demographics of the patient. We tried so much to put in some confidentiality, and the initials of the patient, KA would be the name of the patient. The age was a 65-year-old, sex is a male, and the address he lives in Kanyanya. Some people should mute. The presenting complaint were chest pain and shortness of breath for at least 1 day. It was 1 day. History of the presenting complaint, a 65-year-old male, known hypertensive with a history of coronary artery disease, on unknown medication for about 10 months, presented to the emergency department with chest pain that he says started suddenly as he was fixing a few things at home, and it was as a pressure-like, it was a pressure-like pain sensation. It was in the middle. It was in the middle of his chest, and it later radiated to the side, to the left side of his chest. It was followed by shortness of breath. On examination, the patient was still able to protect the airway. We used the ABCD approach. The patient was still able to protect the airway, but kept on breathing through the mouth. And what we did when the EMT saw that expression, he knew that the patient is experiencing acute heart failure and was at risk of cardiac arrest, and he immediately alerted the physician. Then the patient was making deep breaths with a respiratory rate of 24 breaths per minute and oxygen partial pressures of 92% on room temperature, with a wheeze that was heard on auscultation. We initiated oxygen therapy via nasal cannula at a flow rate of 2 liters per minute, and this was adjusted accordingly. So the patient had palpitations as well, with a heart rate of 130 beats per minute. The blood pressure was 90 per 60 millimeters mercury. And we started an IV line and administered medication as was prescribed by the physician, which included a nitroglycerin patch and furosemide. The patient was also having discomfort in talking, and we advised the patient to avoid talking and rest. There were no marks openings on inspection and general examination of the whole body. No open or bleeding from anywhere. So we closely monitored the vital signs and oxygen saturation, and adjusted the oxygen flow rate as needed as we prepared the patient for the tests that were requested by the physician, which included an echocardiogram and other tests that were requested. We got some sample history from the patient, which the patient reported that he had dizziness, which was that is 2 to 3 days back, with palpitations on heavy sounds while he was driving. He reports no allergies. The patient also reported that he's taking antihypertensive medication, but he doesn't know the names of the drug and he did not come with them at the facility. So after that intervention, we were still waiting for the tests to be done. After 3 minutes, we went back to review the patient while waiting for the requested tests. We performed, we went back to review the patient. And then the patient, using the ABCD approach, his condition had deteriorated and he was unresponsive. He was not talking. We opened the airway. The airway was open, but there was no spontaneous breath. The EMT checked the pulse and there was no pulse. So we tried to see whether there are any breath sounds. There was no breath, and the EMT checked and there was no pulse. Immediately we realized that this is a cardiac arrest, and the EMT activated the emergency response team as he began the CPR with chest compressions. So chest compressions were performed at a rate of 100 to 120 compressions per minute. And when the team arrived, the patient was ventilated with a bag mask device at a rate of 10 to 12 breaths per minute. We continued to CPR until the defibrillator arrived. And when we used the defibrillator, we noticed a shockable rhythm, and we shocked the patient at 120 joules. So after a successful or continuous CPR for about 6 minutes, peripheral pulse was regained, and the patient was maintained on oxygen therapy. So when we got the peripheral pulse, we tried to maintain the vitals, and we maintained the patient on oxygen therapy with close monitoring of the vitals, and then we transferred the patient to the ICU. After a few days, the patient was discharged and advised to return for review after 5 days. So in summary, we have a 60-year-old male, known hypertensive with history of coronary artery disease, that came in with chest pain and shortness of breath for 1 day. He deteriorated after the first interventions until he got a cardiac arrest. CPR was done for 6 minutes in the emergency room. After a successful CPR and the patient stabilized, we transferred the patient to the ICU, and post-resuscitation care and close monitoring and further management was done there. Thank you very much.
Thank you so much for that presentation, Mr. Rutakome. I hope we've all gotten that case scenario. That was a real case scenario. And you've seen how they managed the patient. This is someone who came in walking. maybe talking, but eventually went into cardiac arrest. Good enough, the team had to identify this, recognize the signs leading to cardiac arrest early, and that is how they managed to resuscitate the patient, gain consciousness, and maybe sent to ICU. So maybe after that presentation, we may need some slight discussion or reactions to this, or we go straight into the next agenda. We shall get more concerning that case as we go on. We want by the end of this session, when we can all manage that scenario. At the moment, we are having people who are commenting, yes, but as we comment, let us also listen to these presenters or the experts, and then we shall see where people went wrong during that case scenario management, whether they did well or fairly. To us, at the audience, they performed, but to the experts, are they really satisfied with the interventions? We shall see. So we want to go into how we recognize a deteriorating patient and then preventing cardiac arrest, cardiorespiratory arrest. Another thing, we shall see the demonstration. It is easy to talk, but practically it may not be applicable. So we want to see whether the experts can put this into practical. Is it, we read these things in books, but is it practical in Uganda? So let us give them time and we see. Then, before they leave the floor, after demonstrating to us, we need to know the principles of CPR. What are the principles? Do we just do CPR? During the presentation and the practicals, we shall see all this. Please enjoy. Welcome our experts for this interesting session. I'm also waiting to see. Yes.
Okay, I'm going to tackle the subtopic of recognition of the deteriorating patient and prevention of cardiorespiratory arrests. I believe most of us here are attending this session are clinical or are health workers who are involved with patients at multiple stages before and even during their hospital stay. So I'm going to just give some opinions on what we can do to prevent a cardiac arrest or even to recognize that the patient is deteriorating, to be able to intervene before the cardiac arrest occurs. Okay, next slide. So I think the foundation, and our foundation is the knowledge we have, and it's the best preparation we can make. And so I thought to start with the training or education we have, mostly after school, because we all go to school, but then we need to sustain that knowledge. So the first one I listed was that if we can all be having some kind of training annually or maybe every 2 years, BLS or ACLS, there are courses available in Uganda. Dr. Kavuma is here, he heads one of them by the European Resuscitation Council, I think. The other thing is CMEs, which is what we are doing today. We should also be able to make sure that we attend some kind of medical education sessions that prepare us for this day when the patient comes to us when they are very sick. The other one is very brief. It's having a reading culture to keep improving on our knowledge. And the next slide, and the next. So I'm going to first start by focusing on prevention of a cardiopulmonary arrest in the hospital. And as you can see on the left, I've listed the 5 H's and 5 T's, which we should all be familiar with. So we are going to go through what we can do in the hospital to prevent these 10 things that, if they occur, are likely to cause cardiac arrest. So I will first tackle the vital signs. Many of us take vital signs or are asked to interpret vital signs, and this is a very important thing in the prevention of cardiac arrests occurring. It is how we measure parameters that can show the state of the health of the patient. So the first one there is hypothermia. So the measurement and interpretation of a temperature measurement, of a temperature reading on a patient is very key, in that sometimes people tend to miss it out, and it's a very it's one of the causes of cardiac arrest, especially people working in theaters or in the anesthesia, in the recovery units in the theaters, and people attending to patients who have been drowning or had near drowning. Then hypovolemia is the second one. So we often take blood pressure readings, but sometimes people want to ignore or not make a timely intervention. So low blood volumes and low blood pressures will definitely be easily detectable if we are all taking the vital signs and making timely interventions where we detect a problem with such issues as the blood pressure. Then there is pulse oximetry. With the pulse oximetry, we get 2 things. We get the pulse rate and also the oxygen saturation. And there is also an ECG. So these 5 vital signs or measurements are very helpful in predicting that a patient is going to be deteriorating or is already deteriorating, and you can intervene. So we have to be making sure that our places of work are ready are always having the machines that we need to do this. The next is physical examination, lab work, and imaging. We are always supposed to take this very, very seriously, as that is the only way we can recognize some of these issues. Cardiac tamponade and tension pneumothoraxes will not be missed easily if people do their physical examination well. This goes both to the responders who might find the patient outside of the hospital, or the people who are at the emergency, or even people inside a ward, in case such things develop. Then there is the laboratory work. So we have seen among the 5 H's and 5 T's, we have high potassium, and then we have the hydrogen ions, which can be detected through lab work, but also in the back of our mind when we are managing a patient, if, for example, you know that you're attending to a patient with maybe kidney disease, you should be able to predict that one of the reasons, if they are very sick, one of the reasons that they might deteriorate is because of electrolyte derangement, and especially potassium, also hydrogen ions, also people with respiratory issues. You may want to do their, to find out what their acid-base status is. Yeah, so I'm going to go to the next slide, where we're going to talk about toxins. Toxins is a good cause of, is one of the major causes of cardiac arrests in the hospital, especially when it comes to drug overdoses and misinterpreted prescriptions, especially when you're dealing with drugs that can lead directly to a cardiac arrest, like opioids, and also electrolytes like potassium. So it is good for us to prepare our workplace so that such accidents don't happen. It's good to have some workplaces ask that some drugs are checked by 2 nurses before they are administered. It is good to have proper prescriptions that the nurses can refer to, that are made in the right way with all the details, the drug dosage, time, and even, if possible, the method of administration, or to be specific, how exactly to administer the drug. Then, if there are verbal prescriptions to be made of such dangerous drugs, it is also nice to have some rules in the workplace to guide when verbal prescriptions are made by someone who is not presently at the workplace or who is too busy to make a prescription. We'll go to the next slide. So the next slide is other approaches that we can use in the workplace to recognize the deteriorating patient. There is some charts that are used in several places. One is called the modified early warning signs. Then there is the NEWS score. I don't remember what it means. I need to check again. Then the PEWS score. This is a pediatric early warning signs tools. Now these ones can be used and are used in multiple hospitals to document the vital signs that you take on the patient, and they have a score that the nurse should be able to make. And the total score of these charts can guide the nurse on what to do. They can tell them to inform the doctor immediately if it's if a certain score is achieved. They can ask that you increase the frequency of monitoring if maybe just not a very bad score is achieved. So it's good to try and adopt such tools. The next is timely referral, both internal and external. So as in our case scenario, we had that after the resuscitation, our patient, Mr. K.A., was taken to the intensive care unit. We should all be quick to refer patients, and the willingness to, or the ability for us to learn what we can do or what is within our means is very important for the patient's life. Sometimes you can have all the knowledge, but you don't have the tools, and you have access to a place where the best can be done for the patient. It is good if we can make sure that we make a safe and timely referral when we are doing when we are taking care of patients and when we realize that they are deteriorating. So our patient was quickly taken to the ICU immediately after a few minutes after getting a return of spontaneous circulation, and therefore we should always endeavor to do such things, especially
Slides are not being seen.
Especially before the patient gets a cardiac arrest. The other thing we can do is, so this is referral inside the hospital or outside the hospital. So if you're, say, in a general ward, you might want to take your patient to an intensive care unit. If you're in a hospital without a good emergency setup, you might want to refer to another hospital where the emergency is more prepared. As you give good care during the transport, then I also put something there about good quality post-CPR care, because CPR is usually followed by more cardiac arrests if people are not careful. So some people have a tendency of celebrating too early instead of continuing to treat the patient. When you get return of spontaneous circulation, it's good to go ahead and find out all the causes that could have led to the cardiac arrest and to keep sorting them out. Otherwise, the patient is likely to have another subsequent cardiac arrest. Then documentation of CPR and debriefs, which is a small discussion following every CPR, they help us with follow-up actions to improve the hospital preparedness for other CPRs and emergencies. They may not help for the specific CPR, but they help us to know where we went wrong and what preparations we had not made, and therefore making our way forward for improving our workplaces. Then having a fit for purpose emergency trolley, this is very important in our workplaces. Workplaces that deal with a patient of any kind, or any kind of complication can happen to a patient. There has to be an emergency trolley to help out with sorting the cause of the cardiac arrest. Next slide. So I have also a brief about prevention of cardiorespiratory arrests outside the hospital setting, and this is just brief. One is health-seeking behavior, and we have seen, as in our case presentation today, the man had chest pain 2 days prior to the day he appeared in the hospital, 2 to 3 days. So health-seeking behaviors of people have to be improved because they greatly affect the ability of anyone to recognize that they are deteriorating. So people with signs like palpitations, like our patient had, dizziness, sometimes it means nothing, but sometimes it means the patient is in deep trouble and may end up getting a cardiac arrest. So it's good for people to have better health-seeking behaviors. Then the last one is efficient emergency response teams. And this means the preparedness of people who go to accidents, scenes, and where natural calamities have occurred, their ability to go and deal with the problems that the people have. Some people show up with ambulances that are not equipped to deal with the problems that the patients have, and they end up not being very useful. So it's a good thing that the people working in healthcare make sure that their ambulances are well equipped, and also their emergency department. I think that's it from me.
Thank you so much for keeping that time. We are still going on. So that is recognizing a deteriorating patient. You've seen the 5 H's, 5 T's, and how he has gone about it up to the end. So, Dr. Doreen and Dr. Peter, we want to see how you can demonstrate to us some of these things. We want to see them practically, generally. Though not only a human being, we are going to use a mannequin. Sorry for that. Mannequin, not human being.
All right, thank you so much. So we're just going to demonstrate how you can approach a deteriorating patient who just comes into your unit. So the general principles that we have gone through, now I want to see if the patient is in front of you, what do you do? So Doreen is going to be our clinician who receives this patient from our case study. So it's going to be the same case. So we had, just recap very fast here. So we had a 65-year-old KA, we're calling KA, who is a non-hypertensive with a history of coronary artery disease, who's on an unknown medication regimen and has been hypertensive for about 10 months, who presents now with 2 days of chest pain and shortness of breath. Comes to you to the emergency department.
Okay, so just to recap, we have an adult male KA, a patient with coronary artery disease on unknown medication with chest pain.
Yes.
Okay, is the scene safe for me to approach?
So he has come driving this car and has come to the emergency department and is in your resuscitation area, which is a safe place. So you can approach them.
Okay, all right. Mr. KA?
Yes, Musao.
Okay, so Mr. K is talking to me, which means his airway is open.
Chest.
Okay, so Mr. K, what's the problem?
The chest is really, I feel heaviness in my chest.
Okay, and what does it feel like? Can you describe the pain for me?
I feel like someone is stepping on it.
Okay, so Mr. K has a history of coronary artery disease. He has chest pain, most likely he could be having an acute coronary syndrome. So I'm going to give him high dose aspirin. Mr. K, I'm going to give you some medicine,
Okay.
which you're going to put under your tongue. Okay, so I'm giving him a high dose aspirin under the tongue.
Okay, let me swallow that. Okay, thank you so much.
Okay, Mr. K, so most likely because he has an acute coronary syndrome, I'll also put him on oxygen. So let's start off with oxygen. Let's get a nasal cannula. So we shall attach oxygen. Let's give him oxygen via face mask. Okay, so let's move to our breathing. What's the respiratory rate?
So the respiratory rate is breathing at around 20 breaths per minute.
All right. When I touch my pulse ox, what's my oxygen saturation?
So that's what you see on the screen. I don't know if you can zoom into the screen, but the SpO2 before you put the oxygen was 92. When you put your hand rebreather, it's now going up. It's now at around 97.
96.
Yeah, 96, 97.
Okay, so let's go on to examine the chest. How is my trachea
Trachea central,
and midline?
midline.
How is my chest
It's
expansion?
moving equally bilaterally.
Okay. When I percuss?
Normal percussion note bilaterally.
Okay. When I auscultate?
When you auscultate, there's no more air entry on the left, no more air entry on the right, no more air entry in the bases, no more air entry everywhere.
Okay, so my breathing is sorted. Oxygen saturation is at 96, he's on oxygen. Okay, so let's move to our circulation. I'm going to attach 2 large bore cannula.
Okay, so put that.
And I'll also put him on maintenance fluids, normal saline, 500 mils.
That is running.
That's running. I need a BP.
So BP, you can recycle it.
How is my pulse?
Pulse is just fast, but no more volume.
Okay.
So just pain.
Okay, so Mr. AK, I'm going to give you some medicine to reduce the pain. I'm going to give him some morphine, 3 milligrams. Okay, this is going to help you with the pain.
Okay.
Give him IV morphine. How do you feel now?
It's reducing.
It's reducing. Okay, so we continue the examination. In circulation, let's attach the leads. So if we can look at our monitor, do a 3-lead ECG.
Okay. So when you attach your monitor, that is what you see.
Okay, so from our 3-lead ECG, we have an ST segment elevation. So most definitely we have an acute coronary syndrome here. So because of that, let's give him some nitroglycerin. So some nitroglycerin puffs under the tongue. Let's give him 2 puffs.
Okay.
All right.
So then that he no longer has now chest pains.
Okay. You're feeling better right now?
Oh, yeah, the chest pain has gone. Oh, thank
okay.
you so much.
All right. So let's continue with our ABCDE. We're still on circulation. We're on fluids. I'll have our ECG on. Our pulse is being monitored. Let's now move to our disability. Mr. KA, how is the pain now?
Pain has reduced.
It's better.
Yes,
So he's talking back to me. He's alert. Let's check our pupils.
When you check the pupils, they are equal, bilateral and reactive to light.
Okay, good. What's my blood sugar?
Check your random blood sugar, it is 6.2.
Okay, that's normal. So my disability is fine. I move to exposure. When I expose him, any rashes?
Nothing really,
any bleeding?
Nothing really, just a little sweaty, but nothing really remarkable.
Okay, what's my temperature like?
So measured temperature is 36.2.
Okay.
But you notice he's no longer speaking to you.
Mr. KA, Mr. KA?
He's not responding to you.
Mr. KA, Mr. KA?
Not speaking at all.
Okay. So I'm going to check for pulse. I'm also checking for breathing for 10 seconds. Is there a pulse? Is there a breathing?
So in 10 seconds, there's no breathing and there's no pulse.
Okay, this is a cardiac arrest. I'm going to start CPR and call for help. Help, team. Come and assist me. Okay. We have a cardiac arrest.
All right, help is on its way. Unfortunately, the rapid response team is also handling a cardiac arrest scenario in ICU. So I'm the only one here to help you for now as you're coming.
Okay. So Peter, you're going to take over compressions for me.
Okay.
In 3, 2, 1. Okay, so now that Peter has taken over compressions, I'm going to attach my pads so that I can check the patient's rhythm. Right? So Peter, when I tell you to stop compressions, you're going to stop compressions. So Peter, you're going to stop compressions in 3, 2, 1. Stop compressions. That's a V-feed. Continue compressions. We're going to give a shock. Okay, Peter? So I'm going to charge my defibrillator. Select the maximum joules. Everybody stand clear apart from chest compressions. Everybody stand clear. Stop compressions. Shock delivered. Resume compressions. Okay? So as CPR is ongoing,
8, 9, 10.
Going to ventilate the patient.
13, 14. 15,
so Peter, after 30 compressions, I'll give 2 breaths.
21, okay. 4, 25, 26, 27, 28, 29, 30.
Okay. 1, 2.
1, 2, 3, 4, 5, 6, 7, 8, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. 1, 2, 3, 4, 5, 6, 7, 8, 9, 30.
Right. 1, 2. Okay, cut it there.
Okay, stop there.
Okay. So what we have demonstrated to you is an approach to resuscitation in an adult. We've gone through the first stage where we have demonstrated in real time without explaining too much what we've been doing. The first stage was an ABCDE approach, which is the approach that you will take when you are assessing a deteriorating patient. And then our patient arrested, and we've gone through how we're going to approach a patient who was arrested. We're going to repeat what we've done, but we're going to repeat it while explaining to you. And also we shall take you through the principles when it comes to cardiopulmonary resuscitation in an adult. All right, so let's repeat the scenario, Peter.
Okay. And just remove this.
Right, so we're not going to go back to the ABCD approach. We're going to go starting when he's unresponsive.
Okay.
Right. Okay, so KA is now unresponsive.
Okay, so the very first thing when you have a patient in front of you, it's important to assess for scene safety. Safety is important because you want to ensure that it's safe for you, the provider, but also safe for your patient. So is my scene safe for you to approach?
Yeah, the scene is safe, it's in your ED.
Okay, okay. So the first thing you want to do is you want to assess for responsiveness. So you tap the shoulders of the patient while calling out the patient's name. K-A, K-A, K-A.
Not responding.
All right. So then you want to check for your pulse and you want to check for your breathing. So you do a quick chin lift to open the airway. You go down to the patient to feel for any breath, but you also look to see if there is any chest rise, and you check for a central pulse. And you do this for 10 seconds.
Okay, so when you do that, the quick ABCDE while doing the look, listen, and feel for 10 seconds, there's no breathing and there's no pulse.
So this confirms a cardiac arrest. There is no response, there is no pulse, and there is no breathing. Immediately start CPR. The qualities of good CPR is that your elbows should be straight, your hands should interlock, you should use the heel of your hand, you should position your hand in the lower third of the sternum. So you position your hands right there, and you're going to compress hard and fast. So this means you're going to compress at a rate of 100 to 120 per minute, and then you should compress at a depth of 5 to 6 centimeters. And also you should make sure that the energy comes from your shoulders. As you're doing CPR, you want to allow for chest recoil. So that means that you should not exert pressure onto your patient, but allow the chest to recoil. This allows for the heart to fill up with blood. So elbows straight, energy from your shoulders, interlock your hands, use the heel of your hand, lower third of the sternum, and compress at a rate of 100 to 120 per minute. So immediately you start compressions, call for help because you need a team to support you. Help team, I have a cardiac arrest.
Team is on its way, but you have me as an assistant.
Okay, so immediately your team has arrived, you want to hand over compressions with minimal interruptions. Peter, I'm going to hand over compressions to you in 3, 2, 1. So Peter continues with good CPR, ensuring that the energy is coming from his shoulders, his elbows are straight, he's allowing chest recoil, he's going at a rate of 100 to 120 per minute. Immediately you want to attach pads. The first pad goes right below the clavicle, the second pad goes in the axillary area. Immediately pads are attached, you want to do a rhythm assessment. So Peter, you're going to stop compressions in 3, 2, 1. Stop compressions. This is a shockable rhythm. Resume compressions. So we have a shockable rhythm, and this means we should prepare to shock. You should give a safe shock. So this means that you charge your defibrillator to the maximum amount of joules. For this defibrillator, our maximum joules is 360, but at your facility, it could be 200, it could be 280. So make sure you check your defibrillator at your facility to confirm how much energy it goes up to. So you charge and make sure everyone clears. Everyone clear apart from chest compressions. Everyone clear apart from chest compressions. Stop compressions, deliver the shock, resume compressions. So as you can see, there was minimal interruptions, and we made sure that a safe shock was given.
13, 14, 15, 16.
When you're doing CPR, you have to ventilate your patient. And the science guides that you should give 2 breaths to 30 compressions.
28, 29, 30.
1, 2.
1, 2.
When you're using a bag valve mask, a BVM, give 30 compressions to 2 breaths.
15, 16, 17, 18, 19, 20. 1, 2, 3, 24, 5, 6, 7, 8, 9, 30.
1, 2. So I think we can stop there for the demo.
Yes. So this continues on for 2 minutes. So the cycle of 30 to 2 continues on for 2 minutes. And when it clocks 2 minutes, you pause and reassess the rhythm again. Maybe it has converted. Maybe it is still shockable. Maybe it's not shockable. For this section, we're not going to go into the depth of which one is shockable and unshockable. but you need to know. Good thing is that now in our setting, we have devices that are called automated external defibrillators, AEDs, that you can use, even if you don't know how to identify a shockable or non-shockable rhythm, that you can use, and it assesses the rhythm for you and tells you whether to deliver a shock or not. So those are available, and some machines have them. I think we came with one of them here. So some machines have the AED function on the defibrillator, and if you're not really comfortable in identifying the rhythms, you can just use that and proceed with the cardiorespiratory resuscitation.
Okay.
Yeah.
So immediately you have started resuscitation, you want to start thinking about post-resuscitation care. So in the event, like for this case, they got a pulse and they had return of spontaneous circulation. So well done, what do you do next? And this is the part where now I'm going to dive into post-resuscitation care. Post-resuscitation care is part of the chain of survival. The chain of survival has 4 key elements. So the first one is early recognition of a cardiac arrest, which we've done by confirming the cardiac arrest. You tap the patient's shoulders, you check for pulse, and you check for breathing. The second one is early CPR. We've talked you through how to do CPR and the qualities of good CPR. The third one is early defibrillation. That's why it's very important. As soon as someone has arrested, you want to attach pads to check and see what is the patient's actual rhythm. Is it shockable or non-shockable? If it's shockable, you want to shock as early as possible, and we've shown you how to give a safe shock. And then the last component of the chain of survival is post-resuscitation care. If you don't have post-resuscitation care, your patient is going to arrest again. Now remember, your patient has just had a cardiac arrest. Their heart has not been beating, blood has not been going to their brain and the vital organs. But your patient is now alive, and this is a deteriorating patient. So the approach is A, B, C, D, E. I love the A, B, C, D, E because it's systematic, it's organized, but also it gives you an approach which is very simple, and I believe in doing simple things and doing them excellently. So in your airway for a patient who has resuscitated, what do you want to check for and what do you want? The first thing you want to ensure is your airway open? Most likely this patient is going to need advanced airway management. So most likely you need to intubate your patient or have an LMA in place. The other thing you want to check for in your airway is you want to make sure the patient is on oxygen. So that what oxygen are you aiming for? We don't give 100% oxygen. We give oxygen between 94 to 98%. Why? Because you could actually have oxygen poisoning. So this can be given with advanced airway management, okay? So in your breathing, aim for oxygen saturation between 94 to 98. You also want to support your patient as your patient is breathing. So either you're going to attach your patient to a ventilator or you're going to continue bagging for your patient. The other thing in your circulation, you want to ensure that, one, you do a 12-lead ECG. So you want to identify the cause of the cardiac arrest. You do a 12-lead ECG, identify if your patient has a STEMI, where the STEMI is, and then plan to take your patient maybe for PCI if it's necessary. This is important because if you don't identify the cause of the cardiac arrest, your patient is going to arrest again. In circulation also, you want to aim for normal blood pressure. And the other thing is, it's also important that you also aim for normal volemia, which means maintenance fluids. So maintain your patient on fluids unless otherwise, okay? And then the other thing is that in your D, you're aiming for normal blood sugar levels. So check for your blood sugar, make sure it's normal for your patient. You don't want hypovolemia, you don't want hypoglycemia, you don't want hyperglycemia. The other thing in your disability is you want to sedate your patient. Why do you want to sedate a patient who has just arrested? It's important because you want your patient to rest. The brain has just gone through a traumatic event, but also you want to avoid shivers. You want to avoid overworking the body. So keep the body at calm, keep the body rested, and this is going to be achieved by sedating the patient. When you expose your patient, there are things you want to look out for. And the most important thing is temperature management. So you practice what we call targeted temperature management. We aim for temperatures between 32 to 36 degrees Celsius. You realize that these are lower than the normal body temperatures. Why? Because science has shown that if the temperature is slightly lowered, you're going to lower the metabolism of your patient, and you also want to give the body time to rest and recover. That's the reason as to why most ICUs are actually cold. Now you're going to realize that this cannot be achieved in an ED, this cannot be achieved on a ward, this has to be achieved in ICU. That's why when your patient has arrested, you need to start thinking, where am I going to take my patient? Which ICU is available? How am I going to transport this patient? You've had a patient who has arrested, so you need the right kind of transportation, you need the right team to receive the patient, and also which kind of team is going to receive the patient. Also, your handover is very important. It's important to follow the ISBA format, where you identify the patient, give the situation, give the background, give whatever you have done, the interventions and the recommendation for your patient. Thank you very much. Peter, any additions?
I think you have summarized it well there. So that's how you can approach such kind of patient in real life. I think the next session will be probably a discussion, since you have given you a theory and have demonstrated some here and there.
Yeah.
I think we can open up the floor for questions, concerns, queries. People who are sending in mobile money can give you our numbers as well, and we see how we can move forward. So I'll put it back to our moderator.
Okay, thank you so much for that demonstration. And according to the charts, I see many have really gotten interested in the demonstration and have appreciated. Thank you once again, Dr. Doreen and Dr. Kavma, for that demonstration and the explanation. We shall do better as audience, but you've tried to simplify what used to be difficult for some of us. We are opening the floor for some questions and reactions, but I'll first get some few chats, and then our experts can try to respond. We got a concern from Mr. Opolot Emmanuel. He says, some clarification, why IV normal saline before knowing the blood pressure in a non-HT initially, SCS. Can we first respond to that? Some clarification, why IV normal saline before knowing the blood pressure in a non-HT initially with SCS.
Okay, so I think it was just a failure in our machine. The machine refused to give the reading for when Dr. Doreen was at the part of C, but ideally you would first do the vitals. The blood pressure for this patient, if you had seen it, and it's there in the case was 9 out of 60. So it was just an error on the machine, didn't really bring it up. But yes, it's very ideal to check for the blood pressure, because if it was really high, the emergency ranges wouldn't really rush so much. But the good thing is that you heard what Doreen said, it was just some bit of maintenance fluid for that patient. So yes, it's important to measure that blood pressure before you rush into the
Okay. So, Mr. Opolot, you've had the response. Another concern comes from Miss Nakate Sikola. She has two concerns. One, how fast should the compressions be in adults? Dr. Doreen.
Yeah, so the compression should be given at a rate of 100 to 120 per minute. I know it is hard to explain how you're going to do that. But like our colleague was saying, you need to go for these trainings. You need to do training in BLS and also training in ACLS. So you'll be trained on how to give compressions. We cannot guide you unless you've actually trained, but the more you train and the more you practice, you get muscle memory. So some of us in our practice, we memorize by singing songs. Some of us count. So the more you practice, you realize that my pace is probably slow or my pace is fast. But it's something that comes with practice and comes with training. So I would advise that please do the BLS training, do the ACLS training so that you get a feel of what the pace is. So, but the ideal is 100 to 120 per minute.
Okay. And the second is how many cycles of compressions before doing the ventilation?
So as we saw in our demonstration, immediately you have shocked your patient, you want to start ventilations. If we go back to our chain of survival, the 4 major things that will affect the outcome of your patient, ventilation is not one of them. So the very first thing is confirm your cardiac arrest, good quality chest compressions, early defibrillation, and post-resuscitation. So immediately that you have shocked your patient, then you start your ventilations. I hope I've answered the question.
Yes, thank you. This is Lilian Birungi. How long do you continue the compression cycles and ventilation as you assess the ABC as you did using that approach? How long do you continue the compressions? Because you have to again reassess. Yeah.
So we had to cut the scenario short because of time, but the chest compressions, the heart never stops. So if the heart has stopped because of the disease, whatever is causing it, I always tell our participants that come for the ALS training, the heart never stops. So the idea is you do CPR for 2-minute cycles, 2-minute cycles as you're assessing for pulse. Now the point of assessment, we're not going to do ABCD during cardiac arrest. During cardiac arrest, when there is no pulse, at that point, after 2 minutes of your CPR and breath and shocking, you just pause for not even more than 4 seconds to see which kind of rhythm you're dealing with. That will guide you to what you'll be doing in the next 2 minutes. So it's basically stacked up in 2-minute cycles until when you get back a pulse. Now, when you get back to a pulse, that is where Dorian came in and explained how to approach post-resuscitation care, where you approach now the patient using the ABCDE approach.
Okay, still Dr. Kavma, you could elaborate on this or respond to this. How long, this is from Chisache Erina, how long is the CPR supposed to be stopped in case of no response?
So these are, I expected these sort of questions. These are some questions you get during the training. So I'll tell you I can start with a question to that participant. If it was her husband or mother, how long would she go vis-a-vis a random stranger? So there's a gray area there. There are certain instances, and when you come for this sort of training, we usually tell you when not even known to start CPR. Someone comes in and they're rigor mortis, or someone has come in from our recent rapid accidents and their head is off, they're decapitated. Will you do CPR? Yes and not. So when do you stop? Depends on several factors. How big your team is, because if you're tired and your muscles are all tired, you cannot really force yourself to do CPR. So there are multiple factors to consider when you make a decision. But it's one thing that remains is supposed to be a group decision. Everyone there, as part of the team, should make a joint decision to stop.
Okay, thank you. This is an appreciation from Dr. Ojaku Patrick. Hope I've pronounced it well. If not, please forgive me. He has appreciated, but then he's saying, appreciative of the demo. I think physical drill on CPR and AED would be handy to be certain the skills updated.
Yeah, so I totally agree. But for purposes of training, you can't practice on someone who is actually alive. So we're just using mannequins, but you realize with simulation teaching and the more practice you have, then your clinical skills will get better. Of course, it shouldn't stop here. After that training, it's very important that you go back to your areas of practice and make sure that you put into practice what you've trained. So different factors will affect your approach. Definitely the organization in the ED, your team dynamics, the equipment that you have, the supplies that you have. But it's good that once you go through the ideal kind of training, you have a picture of what you want to achieve. Then when you go back to your facilities where you practice from, you can put into practice what you have trained for and make it applicable to your setting.
Okay. This is from Nakato Agnes, but I'll read even for Nabanja Hanifa. They say, where do you place the pads? She missed out on this. And then the other one for Hanifa, take us through the medications administered as well. I think you can explain.
So
the pads?
The pads, so the pads, the different approaches, I'll go through the most used one. So you can use different placements, but the most common one is to place, and usually these pads come labeled. One goes somewhere and the other one goes somewhere else. These ones are a little old, so the labels have gone off, and I think we had some. So one of them, and make sure when you're placing them, the place has to be dry and hairless. You've seen people doing a quick shave. If someone is here, you can do a quick shave. If they are sweating and whatnot, dry it. The first one goes on the right side, just below the right clavicle, the collarbone. So you place it there. Doesn't matter. Sometimes people are like, which side? Push it there as long as it's in the right place. The second one goes as the it says, still no hair, dry, goes into the left axilla, right? Left axilla on the chest, not on the abdomen. So on the chest, place it there, then you move forward. That will make it simple. But there are other positions that you can explore, but this we usually discuss it on a later date. We don't want to complicate it now. Yeah.
We may forget what we've just digested.
Then during the second question?
So it was about drugs. So what we demonstrated is BLS, basic life support. When you dive deep into SCLS, then you start using medications. And this needs a bigger team. And there are different drugs depending on the kind of rhythm that your patient has. So if your patient has a shockable rhythm, there are different drugs that you give. If it's a non-shockable rhythm, there are different drugs that you give. We mostly use adrenaline or epinephrine. It's used for both the shockable and the non-shockable rhythms, but the timing is different. It's given at the same dose, which is 1 gram, but for the 1 milligram, sorry. But for the non-shockable rhythms, you realize that you're going to give it immediately, and for the shockable rhythms, you give it after the 3rd shock. You also use another drug, which is amiodarone, in the non-shockable rhythms. And when you start adrenaline, you have to give it every 3 to 5 minutes. So that's every alternate cycle. So the drugs are different, but also when you have peri-arrest rhythms, you also give different kind of drugs. We can't exhaust them here, but yes, you need to give certain drugs, and these will depend on the kind of rhythms that the patient presents with.
Okay, thank you. There is another concern. For the someone had brought in a scenario, but let us use our own scenario. Yeah, that one will delay us a bit. This is from Bulegeya. How do I proceed after CPR outside hospital setting and ambulance It's far from the community. The ambulance, I think, is far from the community. How smart or innovative can I be to save this patient now that is CPR in the community? Experts, any can answer.
Yes, I think I'll start with that. We can all contribute on that one. Health service delivery in our country is dependent on a lot of things. So it all starts with health-seeking habits. And our colleague here talked about health-seeking habits. So it starts with community engagement. People should be more aware of the kind of conditions they have. So it means regular checkups. It means advocating for people to come into your facilities, doing something as basic as blood pressure monitoring, blood sugar monitoring, so that someone is aware of the kind of conditions they have. People have lived with very, very, very high blood pressures for a long time, and they don't even know. Some people have peri-arrest, kind of conditions, but they don't even know. So that's where it starts from. The second thing is you're going to realize that as a country, we have challenges with infrastructure. So our road networks, the ambulance systems are not fully functional. We don't have a toll-free number, but also the kind of ambulances that we have might not be fully equipped and also might not have the right people trained to handle these kind of situations. But in the event that you have someone who has arrested in your community, the very important thing is to start the CPR. And I think my colleagues will recognize and start the CPR. The second thing you want to do is call for help. You don't want to die alone. This is a team effort, so call for help wherever you can get help from. And then most likely, if you're going to have help coming in, then hand over to the team to support you. Like I said, it's a system issue, so work with what you have. Do simple things, and these simple things can actually save life. Something as simple as starting CPR can actually save this person's life. Something as simple as ventilating this patient can actually help this person have a better outcome. So it's about picking out the simple things that you can do. Let's not overcomplicate things and try and work with what we have. I don't know if Polikia wants to add something.
For the case of someone who is really deep in the village, I think I always remember one patient we once got, I think in IHK in the ICU, who had come from somewhere in Congo in the bush, but was brought by some UN guys. So the guy had a lot of bleeding because he was shot through the femoral artery and got in a situation where he got near cardiac arrest. So with just the ability to establish an IV access, give fluids and apply a tourniquet, and then have some drugs to sustain the blood pressure of the patient, the people were able to transport the patient for about 8 hours to Kampala. So other problems may occur like tourniquet time or what, but if you save a life, sometimes it doesn't take a lot. If your patient is dying or is getting a cardiac arrest because of hypoglycemia, you're having a glucometer is enough because you will act fast. You do CPR, and maybe if you sort out the glucose issue, the next 5, if you start the CPR early, the next 1 to 4 cycles, you're likely to get a return of spontaneous circulation. If it's potassium and you act quick, you can get return. Then now your struggle will be post-resuscitation care, which is what doctor was talking about here. But there is a lot you can do with having just the minimum. But most importantly is what you do with the time when you have no patient with a cardiac arrest. You anticipate that one day you'll get, and it could be any of the causes we discussed. That's your time to prepare, to know that what do you have in your in your store or in your crash cart that can help you rescue someone. And then the other is the knowledge, because if you don't keep reading about these things, you'll even fail to do to find out that it's actually just as to pinpoint what has actually caused the cardiac arrest. Yeah.
Okay. I think with that explanation, we are at it. Community, your hospital is easy because things are available, but in the community you may get stuck. So there is this is Mugisa Godfrey. Are IV fluids a must regardless of the BP and pulse rate measurements in cardiac arrest?
There are different factors, and I just want to draw your attention to what Kamau was just about and what he talked about in his presentation. So, and there are still participants. One of the reversible causes is in cardiac arrest is hypovolemia, one of the H's, and there are different scenarios that can make it a primary cause or something in the background that might be contributing to sustained cardiac arrest. So the speed at which you're going to give these fluids, or and when I say fluids, I'm also including blood if it's blood loss. Though blood is not a fluid, but giving something to replenish the volume. How fast you give it depends on whether you think hypovolemia is a primary cause or if it's secondary. If it's a primary cause, you're going to give it fast. If it's not a primary cause, there are two reversible causes that usually treat in the background as we are trying to look for other causes. Hypovolemia is one of them, and hypoxia is one of them. So when you're doing all these things, you always have to do a bit of intervention for those two reversible causes. So running some fluids in the background, even if you're thinking maybe it could not really be, for example, if it's tamponade, you still need the fluids. Remember, the bladder has stopped moving because the pump is not working, it's stopped. So, it's expanding the volume at that point, and you are giving the chest compressions, will probably, the system works better. That's how I can put it. But it will depend on whether it's your primary, cause of the cardiac arrest or not. Okay.
And then there are many, thank you for that response. There are around 12 people who have a concern of why do we sedate? Yet there is already a compromised GCS and respiration. So why do we again sedate?
Yeah.
Then rationale for furosemide and IV fluids at the same time, yet hypertensive. So that word hypertensive, yet so it's like we are forgetting the BP of this patient, what we got. So we are basing on hypertension. At this time, it is not HT, but is an HT patient.
Yeah.
Okay, maybe you can try to respond to that. Why do we sedate these patients, yet they have already a compromised GCS and respiration?
Yeah, so that's a nice question, but I think it's also important for us to, let's not forget to treat the patient. Yeah, let's treat the patient. So you want to individualize care, which means make an assessment. If my patient needs more fluids, give more fluids. If my patient gives less fluids, give less fluids. For every intervention you're doing, there has to be a reason, there has to be a justification. So it's not gold standard that for every patient, I'm going to run fluids, I'm going to give 500 mils of saline. No. Do an assessment of your patient. You realize some patients are actually in need of more fluids or less fluids, okay? Why sedate the patient? So there are different drugs that can support you to sedate your patient, and they all work differently. I know your worry is someone has just gotten out of a cardiac arrest, why should I sedate? But the science has shown that you want to sedate for two reasons. One, you want to lower the metabolism of your patient. Remember, someone has just had an event where blood is not being supplied to the brain, blood has not been supplied to the heart and the kidney and other vital organs. So you want to give the body time to recover from this traumatic event. If you keep someone awake, fully awake, and when I sedate, I don't mean completely knock them out, no. So again, treat the patient, individualize your care. For some patients, you realize that you might have to give more sedation than others. So after someone has arrested, someone has gone through this traumatic event, you want to lower their metabolism, and it has to be in a controlled setting. So there has to be monitoring done. The patient has to be on a ventilator to support the breathing. So you want to make sure this is a controlled environment. That's why your patient needs ICU care. So most likely you're going to take your patient to ICU where they can monitor the patient, making sure that there's the right team to support you. So you sedate to lower metabolism so that your patient can recover, your patient can rest. But also you sedate because you want to avoid convulsions. You want to avoid this person having abnormal brain activity, and the convulsions can put someone at risk of having a further cardiac arrest. Remember, with a convulsion, you're consuming glucose, you're consuming oxygen, but also you're putting the body through another traumatic event. Those are the reasons you sedate. Again, this drug should be given by someone who is trained, someone who has gone through this kind of training, someone with experience and someone with the expertise, because you're giving different drugs that work in different ways, and some of them can actually even cause a further cardiac arrest. So be very careful with the kind of drugs that you give, because as Andrew was saying, some of them are going to cause intoxications. You could give a drug overdose and put your patient at more harm than good.
Okay, thank you so much. Let's pick there are some people who have put up their hands. Wambale Geoffrey, are you still on line? Wambale Geoffrey, unmute and air your concern. Hello, Wambale Geoffrey? Wambale Geoffrey, are you on? Okay, another hand. Kaduma Gerald. Kaduma Gerald, unmute, air your concern, please. Hello, Kaduma Gerald. Oh. Can Alex Ruhangario unmute and air your concern?
Okay, thank you, doctor, for the presentation. My concern is,
Who is this?
sedate after
Alex? Is that Alex? Okay, please, go ahead.
Yes. Yes. My concern is, do you sedate after defibrillation or before?
Thank you so much for that question. I just come in to answer that quickly. So let's say, like Dorian said, sedation is individualized. For this particular case we had planned to do sedation, some bit of sedation, but not even, and I don't want to see people after getting ROSC starting to give people diazepam. You're going to be causing more problems. Sedation is a plus or minus, it's not always there. So that said, it's not really required for all the cases, like Doreen says. It's on a case-to-case basis. Sometimes you can get ROSC and the patient is already deeply unresponsive, or GCS is now low, 3 or 4 out of 10. You cannot really sedate such kind of patient, and this is a commonest presentation. From cardiac arrest, they don't just wake up like in the movies, like, hey. No, they're usually really, really deeply comatose. So for this case, our patient was more awake, was struggling. Yes. So that's why we gave some bit of sedation. It was something that we had pre-planned a little. So let's not really focus so much on this sedation issue, because the core issues is how to do good quality chest compressions and how to give a safe shock with the ABCD approach.
Exactly. So, early recognition, how to do a CPR, calling for help, what next? That is what we should be looking at more, not more on drugs. Otherwise, we may fail to resuscitate our patients. All right, after you air your concern, please put down your hand. Can we listen from Bakahika? Leonard, Unmute your concern.
Thank you very much for the presentation, team. Quite a commendable job you've done there.
Thank you.
My concern still goes back to MOH. There's a time I had a STEMI patient and it was coming to close of evening. We called the Uganda Heart Institute. They said, we can wait for you until around 9. From Uganda to Kampala takes around 4 or 5 hours. Can we have other centers that can be able to help us when we have these coronary patients? Because it's quite cumbersome getting a patient from these rural areas to Kampala on time. And if Uganda Heart Institute is not working at night, all our efforts are washed down. Thank you very much otherwise.
Point noted. Point noted. Thank you for that concern. Can we hear from Mr. Ojok Roman Justin? Unmute and air your concern, please.
Thank you so much for everybody inside there. I'm Ojok Justin Roman. I'm a driver for ambulance. Could this fit our care center for? My concern is about like handling the patient on cardiac arrest. Because some of us, like drivers, they have not taught us to fully how to handle such people. But the challenges we have on this region, at least in Kampala, they have their emergency nurse or emergency technical people. But for us in the village here, we don't have this people. So now, they limit us from touching patients, from maybe doing other things. But always we do referral only drivers and patients. How could we handle such situation on the scenes or from the facility where we are going to pick the patient to the referrals in case on the way the patient has changed condition? How should you handle that scenario? Because in our region, they told us drivers, we have some few staff, we can escort patients to the facility, or you are going to pick a patient from the village, you have to move alone. And this is a concern always we have. I don't know how you people will address on that issue. Thank you so much.
Yes, any response?
Yes. Like I said, this is a system issue, and it's very important for us as providers that we advocate for certain things. But before you can advocate for something, you need to know what you're advocating for. So you need to advocate in the right way, and the right kind of advocacy should be done. So you know, as ambulance drivers, that human resources is a problem. We know in our communities, in our health facilities, human resources is such a big problem. So advocacy starts with individuals. I think at a health center level, you should advocate to your supervisor that you should ensure that if a patient is critical, if a patient needs monitoring, advocate to have a nurse on board. Put your foot down and insist that this patient shall not be transported unless you have a nurse to escort this patient. That's how advocacy starts. And you ensure that as you keep advocating for things, systems will improve. Systems are not built in one day, and systems are not run by machines, they are run by people like me and you. So it all starts with advocacy, but like I said, advocate for what is important. The right kind of channels should be followed. But before advocacy is done, make sure you have the right information. That's why it's important, Andrew was saying, make sure you get training. How will you know how to use the defibrillator unless you've trained for it, and then you want to advocate for a defibrillator? How will you know how to use drugs unless you've gone for training and you know how to use the drugs? Some of you will start complaining, we don't have AEDs, we don't have these drugs, but you don't even know how to use them. So it's important, before you start advocating for things, get the training, get the basics, so by the time the advocacy comes through, you know what you're talking about, okay? So my advice would be advocacy, but before advocacy, build on your knowledge, build on your skills, so that when you can advocate, you come from a point of information.
Okay. And then remember, we have critical care nurses. Advocate for such. But as they're saying, you may advocate when the equipment is not there. You are not even trained. You even don't know how to use some of these equipments. So we are saying, train, advocate, do, practice, 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 and be positive that one time you'll be at that level. Even these people started from zero. They are now somewhere, and their wish is, I wish all health facilities could have these equipments. We could all have the knowledge. They have the knowledge, but whom are they giving the knowledge to? And then after I getting the knowledge, am I going to practice? So they're not looking at drugs alone. They want us to recognize, be able to do the CPR, be able to refer, be able to call for help or consult. We shall be there. All right. Then we have our own. I can see your hand is up. Mr. Rutakome Jamada.
Yes, thank you very much. Thank you very much, Dr. Dr. Doreen, thank you very much for the demonstration. Everything was good. The only thing we have not talked about is referral. We really like our sister here, Madrid, Juliet. She gave us a case of a 72-year-old male, non-hypertensive, over 10 years. He came with her on written refill, and the BP was 177, 120, but pulse was 72. So what they did is to stabilize the BP, and then shortly the patient got difficult in breathing. So there are cases we didn't comment on, like when to stabilize which BP, because it might be, you might look at it and say it is not stable, but yet it is stable for that kind of patient, because not every patient has the same BP. And another thing is people should differentiate between basic life support and advanced cardiac life support. If we don't have the necessary machinery, we should not opt for advanced cardiac life support, because you will give the medication and then the patient will, instead of coming back to life, will eventually die. The BP will continue lowering because of the medication you've done what you've given. And so that is my comment. Thank you very much.
All right. Thank you, Mr. Jamada, for that. Nakate Sikola, are you on? Unmute, air your concern, please.
Yes, I'm on.
In seconds, please.
It's okay. So good afternoon, all of you. Thank you for the presentation. I really enjoyed, and it is really productive. Dr. Nakate Sikola, working from Chiroko Hospital. So I really want to share something that has been burning for some time. And this is how best can we, with the health workers, engage the community, I mean the layman, in acquiring the knowledge of resuscitation. I mean, I've been seeing very many scenarios that have been happening, and the last one has happened Freedom City, whereby you see people are really, maybe they have a respiratory arrest or cardiorespiratory arrest, but what ideally people do is to maybe get a piece of cloth and they're just trying to provide some bit of fresh air, not necessarily maybe trying to assess, maybe feel for the central pulse, look at the chest. I mean, how best can we do this to make sure the community also gets involved in this? That is my question. Thank you once again. And secondly, I think the challenge that we as health workers are facing, true, majority may not be having the skills and the knowledge, but at least even those who have. The challenge is after doing your resuscitation, patient has stabilized, what next? Maybe referral, or if you don't have, but even where you're referring to, the ICU itself, the space is limited. First of all, it's very expensive. So maybe those are the challenges also we face. But as said, let's first opt for maybe getting the skills and the knowledge, and we make sure with time we shall be there. Let's be positive. Thank you.
Thank you so much. Dr. Kavuma?
I think I had something to do with community, sort of like engagement and resuscitation. So we have, we're engaging with several partners to help us roll out, for the most part, basic life support and use of AEDs into our communities. I'll report to you that we got a small grant and from the government of Uganda to develop our own automated external defibrillator through a grant from the government of Uganda through Makerere University. And we've been working on this for the past 1.5 years. We're almost there. We're testing that. So hopefully, UDB, Uganda Development Bank, is going to be investing a lot of money for us to put these AEDs out in the community. So like Doreen says, it's a system, it grows slowly. We're going to get there. So as soon as these things are out there in the community, we shall be doing more rigorous trainings out there in the communities. And alongside that, I'm hopeful that the people that are working in the ICU development and space expansion will also be doing their part. So it's a process, but we're getting there slowly.
Okay. Yes, as we are coming to the conclusion, we are trying to answer your questions or concerns, and keep sending in your concerns, please, but through an email. Yeah. More questions can be forwarded to the email on the chat. And then I would like to recognize some members who have been on, who are ever on, whenever there is a session here. I'll have to first begin with home. Masaka Regional Referral. I've seen many intern doctors there. I've seen my colleagues there. Thank you for attending this session. I've seen Mbarara team led by Natkunda Silvia. You are on. Keep always on and keep practicing. There is a KCCA team. They're on. Shall seen you. Thank you for logging in. There is Life Saving Association of Uganda. We've seen you. Thank you for logging in. Ginger, we've seen you. Bishop Caesar Asili Luero, thank you for logging in. And many more people. Whom have you seen who is ever online? We appreciate.
I see Oscar. Oscar is a really good regular attendant. Dr. Oscar Aron is one of our instructors at the Emergency Care Forces Uganda.
Okay.
ALS instructors. Very good. He always tells me about these sessions. Yeah.
Thank you for logging in. I saw one member from Mbale Emergency Department, Mbale Regional Referral Hospital. Please continue practicing. Even Arua is online. Arua is online. You've been seen. We appreciate your attendance. Actually, many private sectors.
I know some of my colleagues from IHK as well. I've seen some of them, one or two here, Castro. Yeah, thank you guys for logging in for the emergency department at IHK.
Okay, thank you so much. Whoever has logged in, please, we appreciate. And please send your concerns, enroll for the training, recognize these patients, and save them. We have a post-test, which is coming up. Remember, when you have a pre, you must have a post. So we want you to answer the post-test and see how you can perform. What I know, you are no longer at 0. Or if you are at 50, you are now at 75. Okay? But if you can clock 100, well and good. And then you can challenge our experts. All right? So, if there are more concerns, I give only one hand, only one lucky person, only one. And then when you put up your hand, I want you to give us some remarks. Is there any? Yes. Natkunda Sylvia, you were the first. Oh, many hands. People are on. So interesting. So I'll take the first hand. Natkunda Sylvia, unmute. I give you 2 seconds.
Hi everyone, I greet you all. Happy New Year.
Happy New Year too.
I'm happy for this day. I would like to recognize Dr. Kavma and Dr. Doreen for mentoring me on the first day to be in emergency. Thanks. Bye.
I remember we met in Ginger.
Yeah.
Like 4 or 5 years ago.
Yeah.
Okay.
Keep up the good work, Sylvia, where you are. You are a champion.
Okay. Thank you so much. We are closing the hands for now. Please, we want the post-test done. But as we are doing the post-test, we need some summarized take-home points from our experts. And therefore, one is online. So those ones in the room can begin. Just a minute.
Thank you so much, guys, for attending. I've seen we have reached 500. I think that's the maximum.
Exactly.
That is good. I saw at one point we reached 500 participants.
Towards 500 for some good time.
Yes. So let's take this as a preamble to much more knowledge and skills that can be available through to you guys. Like Doreen says, we have a training center, the Emergency Care Process Training Center, where we're going. What we have just done in two hours, usually it's a course, usually takes for ALS a month, and BLS can take a half day to pass on the skills where you can learn all these things, know the rhythms, learn the pre-arrest rhythms and all this. And you always see our posters of available courses running through different social media platforms. So from this session, as part of this takeaway, learn and maximize the 4 areas that Doreen talked about. Those pillars are very important. Recognition of cardiac arrest, initiating emergency medical services or calling for help, early CPR and early defibrillation, and post-resuscitation care. Those are the core that have been shown to improve outcome patients that have cardiac arrest. I'll leave it at that.
Okay, thank you.
So my take home is going to be very brief. I work in systems and policy, and one thing I'm always telling people that I work with is that you have an opportunity to create something that can improve the life of someone in the future, and that's very important. As you practice in a way that you are creating a system that is going to improve the life of someone coming after you, or it could actually even be you. So as you take home whatever you've picked up from this session, think about ways that you can improve your practice back at your facility. It all starts with acquiring knowledge and skills, because like I said, you cannot advocate for something unless you have knowledge about it. So make sure you pick as many skills as possible. Learning never stops. And remember, you're trying to build a system that's going to improve the livelihood, not only for you, but for our future generation. Thank you so much for tuning in. Thank you so much, Seed Global Health. Thank you, Minister of Health. Thank you, our moderator and my colleagues. This has been a very interesting session for God and my country. Thank you.
Wow. We can listen from you.
Okay, my closing remarks are very similar to those of Dr. Doreen and Dr. Kavuma. It's up to us to keep improving our knowledge. Otherwise, the day when it comes and we are, especially those of us, those who might be here and they don't deal with cardiac arrest very frequently. Some are lucky, they have to deal with one once in a week, twice in a week, and they learn easily from colleagues. But if you are in a place where you rarely do CPR or patients die without CPR being provided to them, it's up to you to learn these things and help these patients. So you can take the courses being provided, you keep attending such CMEs. Thank you for attending today's, and you can also read material on the internet. Yeah, thank you for attending.
Okay, thank you so much. Closing remarks. Okay, take home points from Mr. Rutakome.
Yes, thank you very much, team and colleagues. First of all, I would like to thank the Ministry of Health, EcoSeed, and Emergency Services for this beautiful and knowledge-giving session. It was very good. Thank you very much, Dr. Dorina and Dr. Kavuma. The demonstrations were superb, but as a take-home, I would like to advise our colleagues that acquiring knowledge and skill is one, application is the second thing. Confidence is one of the things that we would wish all health workers to have while managing cases. Not overconfidence, but confidence. When we see even these things happen, I remember during the first and third fast, there were very many people around the pool sides of different recreation areas, and these cases happen there. It might not be only cardiac arrest, but even people were drowning in swimming pools. If you're a medical health worker, please, and you see these cases, don't lose confidence. And some people get iced up and they cannot practice what they have learned. Please apply the knowledge, and it is only through application that the skills will develop and develop. Thank you very much, everyone.
Thank you so much for your take-home points. And the post-test is going on. Post-test is going on. Are you at 100 or 50% in post-test? All right, let us look at how people have performed. Since we still have our experts in the house,
so the post-test has been shared. We have people giving answers to different questions. Question one, most of the people said that the question was, which of the following vital reading in a 40-year-old person is likely to lead to a cardiac arrest if not attended to urgently? And most people, which is 61%, said that respiratory rate of 4 per minute. That was 61%. And then we have a small percentage, 27%, saying that heart rate of 140. I don't know who wants to give a comment on that. Dr. Kavuma?
Yes, so if you look at it, most of those things were worrying. I had when I was reading them. But if you go through the ABCD approach, the first thing that you will identify would be probably air when breathing. And I see respiratory rate of 4, that's the one thing to identify first. And this is something that we need to intervene on as soon as possible. Because the heart rate of all those things will come in after you have identified this in the ABCD.
Thank you, Dr. Kavuma. Question 2 was saying, what is the best time to ensure a hospital emergency trolley is well prepared? And 94% said daily checks, and that was the right answer. I don't think we need to give any comment. Thank you for knowing that. Then question 3 was saying, what is the ratio of CPR to bag and mask ventilation during a cardiac arrest? And 86% saying 30 to 2, which is the right answer. And then a small percentage, I don't know, moderator, where these ones were, but they were thrown all over. So, but we should all know that it is 30 to 2. Yes. Then question 4 saying, what is the first thing to do when approaching a patient out of hospital with a possible cardiac arrest? Responses are thrown all over, from immediately starting CPR, call for help, and then ensure your safety. Dr. Doreen, this sounds like a question you said.
Yes, so remember, as you approach a patient, safety is very important. That's the very first thing you should ensure. You should be safe for you, but also safe for your patient. If someone has had a cardiac arrest and there is oil spillage around, or there is something like a tree that has fallen down, you'd have to approach with caution. So the very first thing is safety, especially in the community, but also at our facilities, ensure safety.
Okay, so safety.
Yes.
All right. Your life first. Please, your life first.
Don't be a hero.
Don't be a hero.
You die.
Don't die in the process. We still need you.
Yeah.
Yeah.
Moderator, back to you. We do the screenshots. Those
Okay.
ones to put their details.
All right. You can put on your videos, please. We want to take a screenshot.
Enrico Michael, I don't know which facility you're at. We have you in a group. I hope other people are paying attention.
I see a lot of my colleagues there.
Because they were named.
I think you can acknowledge.
Yeah, I've seen Dr. Muviru, orthopedic surgeon. I see. So that Edward Isha. So, a lot of people that have reached out wanting to do the training. Yeah, my WhatsApp is available. You can still reach out.
Thank you so much all for attending. We shall see you in 2 weeks. Happy New Year. Take good care of yourself. We have an email we've shared. It is info@emsecho.ug. It's that simple. If you want to send any questions, please send them to that email address. I'll be happy to see you in the next session.
Now, bye.
Bye-bye.
Bye-bye all.
People, you know, we went to maximum. And people were still logging in.